Sodium is a positive charged ion that it accounts for about 90% of cations or positive charged ion in the body. It helps regulate extracellular osmotic forces. It is also very closely related to chloride. Another thing with sodium is it helps regulate the body's water balance. With sodium in the body, you can have hypernatremia, which is a excess serum sodium level of greater than 147 milliequivalents per liter. And it can be due to sodium gain or water loss. Some of the symptoms that you can see with a hypernatremia is thirst, fever, dry mucous membranes, hypotension or low blood pressure, and also low jugular venous pressure. And some of the causes for hypernatremia can be due to excessive hypertonic salt solutions, IV hypertonic salt solutions, and then also can be due to a syndrome called Cushing syndrome. Now another problem with sodium that you can have is you can have hyponatremia. That is when serum sodium levels are less than 135 milliequivalent per liter. It is one of the most common electrolyte disorders in hospitalized adults. It is usually caused by diuretics. And some of the symptoms that you can see is you could see cellular swelling, lethargy, you could have headaches, confusion, seizures, coma, hypotension, tachycardia, and decreased urine output. And some of the causes for that can be also due to inadequate intake of salt, excessive diuretic therapy, so that's going to be like Lasix use or excessive use of thiazides. It also could be due to excess water intake or cirrhosis, and also cardiac failure. With chloride, it is a negatively charged ion called an anion. It provides electroneutrality. That is particularly with sodium. So it follows sodium in ATP. It is it's passive in the transport system, and it also is proportional with changes with sodium. So it follows with sodium. Some of the things you can see with increased chloride, also called hyperchloremia, is elevation of chloride is above 105 milliequivalents per liter. Like I mentioned, it follows sodium, so it accompanies hypernatremia. There are no specific symptoms for hyperkalemia, but you do have to find the underlying disorder to treat. And then it accompanies hypernatremia as well as plasma bicarbonate deficits. So the opposite to that, or low chloride, would be hyperchloremia. That is chloride that is less than 97 milliequivalents per liter. It usually occurs with hyponatremia or elevated bicarbonate concentration. This is common with cystic fibrosis patients. And then again, with symptoms, you must treat the underlying cause. There are not specific symptoms for chloride. And then cystic fibrosis is a genetic order that is mainly linked to sodium that is mainly linked with hypochloremia. It is also due to sodium deficit, and you must find the underlying disease to treat. Another is potassium. Potassium is a positively charged ion or cation. It is one of the major intracellular electrolytes. It is found in most body fluids, and it is maintained by renal excretion. So with hyperkalemia, That is a elevated potassium level of greater than 5 milliequivalents per liter. So with hyperkalemia, it is from a shift from intracellular fluid to extracellular fluid. It can be due to decreased renal excretion. It's relatively rare to see it, and due to renal efficiency. So the renal system helps keep it efficient, so it's not something that is super common. So some of the symptoms that you will see with this would be dysarrhythmias, bradycardia, cardiac arrest. You could see increase in anxiety, tingling. You could see some nausea, vomiting, or hyperactive muscles. And then it's mainly due to excess dietary intake or excess IV intake. It could be due to decreased renal loss, renal failure, and then, like I said, the shifts from the intracellular fluid to the extracellular fluid could be due to cell injury or metabolic acidosis. So the opposite of that would be hypokalemia. That is when the potassium level is less than 3.5 milliequivalents per liter. It is measured through plasma, so that is how you're going to measure that potassium level. Its concentration, it's measured through the plasma concentration due to difficulty to measure potassium. It is caused mainly by GI or renal disorders, so that's gastrointestinal or renal disorders. Some of the symptoms that you can see is it is mild or symptomatic until severe, but you can see skeletal muscle weakness, smooth muscle atony, and then cardiac dysrhythmias. And it is generally going to be caused due to decreased intake, could be caused by starvation, renal loss, renal tubular failure, K-losing diuretics, or potassium losing one. So that's going to be like your Lasix that doesn't spare that potassium. Could be due to vomiting or diarrhea if it's excessive. Another would be a condition called hyperaldosteronism. Another is going to be magnesium. Magnesium is a positively charged ion or cation. It is the second major cation, and that it is second to potassium. 40 to 60% is stored in muscle and bone. A small amount is found in the serum, 1%, that's approximately 1%. Low serum levels cause conservation of magnesium. So hypermagnesia, magnesium is a concentration greater than 2.5 milliequivalents per liter, and it is also usually caused by renal failure. Some of the symptoms that you can see is nausea, vomiting, muscle weakness, bradycardia, or respiratory depression. So it's going to be a decrease in respiratory. Some of the causes can be renal insufficiency, excessive intake of magnesium containing antacids, and then also an adrenal insufficiency. So the opposite would be hypomagnesemia. The concentration is less than 1.5 milliequivalents per liter. So this is increased in neuromuscular and tetany are present with this. It is associated with diabetes, insulin resistance, and osteoporosis. Magnesium inhibits potassium channels or loss of magnesium, which moves potassium out of the cell. It is very similar to hypocalcemia, and that is due to you see symptoms of depression, confusion, tetany, irritability, increased reflexes, and tachydysrhythmias. It's usually due to malnutrition or malabsorption syndromes. It can also be caused by alcoholism, urinary losses, and loop diuretics. Another is calcium. Calcium is a positively charged ion or cation. The total body content for calcium is around 12,000 grams. It is found 99% in the bones. and it is also a major cation associated with the structure of teeth and bones. It is regulated by the parathyroid hormone, vitamin D, and calcitonin. So with hypercalcemia, you're going to see excess serum calcium greater than 12 milligrams, and it is caused by decreased cell membrane excitability, or it causes decreased cell membrane excitability, most commonly due to parathyroidism. So with symptoms, many are nonspecific, but you can see some mental status changes, confusion, kidney stone formation, impaired renal function, and constipation. And now a lot of times it is due to hyperparathyroidism or excess intake of vitamin D, cervical cancer, parathyroid hormone tumors, and calcium-containing antacids. Hypocalcemia is the serum calcium level of less than 8.5, and that is usually due to inadequate intestinal absorption. It decreases the levels of the parathyroid hormone, and then a lot of times nutritional deficiencies. So some of these symptoms that you will see, you'll see tingling, muscle spasm, intestinal cramping, hyperactive bowel sounds, osteoporosis, fractures. You could see convulsions or prolonged QT intervals. Some of the mechanisms is due to deposition of ionized calcium, inadequate intestinal absorption, a decreased parathyroid hormone or vitamin D levels, inadequate sources of dairy or leafy green vegetables, or due to alkalosis. And lastly, phosphate. So phosphate is a negatively charged ion or anion that is found primarily in the bone, about 85%. A normal level for phosphate is 2.5 to 4.5 milligrams, and that is what is normal. It is in a form of ATP, provides energy for muscle contraction. It is regulated by the parathyroid hormone, vitamin D, and calcitonin as well, so it is similar to calcium. Hyperphosphatinemia, which is a phosphate level greater than 4.7, so it could be exo or endogenous, an addition of phosphorus to the extracellular fluid. So a lot of times it associates with chemotherapy due to cellular destruction and release of phosphorus to extracellular fluid. Some symptoms, it is very comparable to hypocalcemia. So you're going to see a lot of the same symptoms as mentioned with hypocalcemia. Some of these mechanisms can be due to renal failure, and like I said, chemotherapy due to releases of large amount of phosphorus into the serum or into that extracellular fluid. It also can be due to long-term use of laxatives. So the opposite would be the hypophosphatemia, and that is a serum phosphate level less than 2 milligrams, and it is due to intestinal malabsorption, is one of the most common causes, and or also due to vitamin D deficiency. So symptoms are not clinically evident until severe, but you could see reduced capacity for oxygen to transport red blood cells. So leukocytes and platelet dysfunction are usually associated. There's a greater risk for infection and blood clotting impairment when you have that. And then the mechanism is malabsorption syndromes are common. Alcohol abuse could be due to vitamin D deficiency, as mentioned, respiratory alkalosis, and increased renal excretion. So increased renal excretion is another one. So some of the electrolytes mentioned are both, either hypertonic or hypotonic. And so I thought I would explain that a hypertonic occurs when the osmolality of the extracellular fluid is greater than normal. And then with hypotonic, it occurs when osmolality of the extracellular fluid is less than normal or less than it should be. So hopefully this helped explain it just a little bit better.